Afternoon, Barry. How are you going?
Oh, good afternoon. How?
I'm good. And are you comfortable where you are?
Yes.
Pillows okay?
Yes, a little bit.
All right, lovely. Now, we've had a little bit of a look at your gait, and one of the things that we noticed when you're walking is that when you're walking, your heel's not always going right down onto the ground, especially with your right leg.
Yeah.
So what I'd like to do is have a little look and see what kind of things could be contributing to that.
Yeah.
Okay. So the first thing I'm going to do is just get you to pull your toes right back for me as far as you can. So leaving your legs flat on the ground for me. That's it. Pulling your toes back. Can you point your toes down to the floor for me? All the way down. Very good. Now this time, I want you to bring your toes up towards your head as hard as you can. Don't let me move you. Don't let me move your feet. Wonderful. And this time, pushing your toes right down to the ground into my hands. Wonderful. Good. Okay. Now, just there, I was just testing the strength to see how the strength is in your ankles there. The next thing I'm just going to have a look at is the range of movement you've got in your ankle here.
Yeah.
Okay, so again, I'm just going to get you to pull your toes up towards your head. That's it. And just comparing that to the other side there. And that's it, and pointing your toes back down to the ground for me. All right. Now, I'm just going to pop this roll under your knee. Okay. And it's just under the one leg at the moment. And I'll get you to pull your ankle back for me as far as you can. Just leave your heel on the bed for me and pull your ankle back and back down to the ground. Point your toes down. Okay. And I'm going to swap it over to your other leg. Okay, and again, toes up towards your head. Good. And pointing your toes down. Well done. Okay. Now, this time I'm going to have a bit of a look at the sensation in your legs. So, can you feel this? Can you feel me touching you there?
Yeah, just. Yeah.
On that side?
Yeah.
And down here?
Yeah. Just.
Okay. So, I'm going to get you to close your eyes for me. And when you feel me touch you, I want you to say yes. Okay? So, closing your eyes for me.
Left. Left. Left ankle. Left bottom. Other one. Right.
So just say yes or no, Barry.
No.
If you feel me.
Yes. Yes. Yes.
Okay. Thank you. You can open your eyes now. Actually, no, I don't need that one. Okay, so the next thing I'm going to test is just to see whether you know where your ankle is moving in space. So what I'm going to do is I'm going to position your left foot in a position, and I want you to try and match it up with your other foot. Okay?
Yeah.
So for example, if I am bringing your foot back, just relax for me. Yep. So let me move your foot for you, and I want to see if you can match the same thing with your other leg. You can match the same movement. Oh, it's all right, I don't have a roll for both. Okay. So closing your eyes for me and matching it up for me. Okay, just relax for me on this leg. Okay, great. Now, the last thing I'd like you to do, you can open your eyes now. I'll get you to sit up onto the edge of the bed for me, and I'm just going to test your reflexes in your legs, okay?
Okay.
All right. Okay. All right, Barry, so the next thing I'm going to do is I'm just going to have a look at how your muscles are contracting and relaxing. So I'm just going to do a quick movement with your ankle to see how we go, all right?
All right.
So when you're ready, so just relaxing your ankle for me. Comfortable? It's all right?
Yes. Yeah.
Okay. And just on the other side, just relaxing this foot for me. Okay. All right. Now I can get you to sit up onto the edge of the bed for me. Right to go, Dave.
What's that, a drumstick?
So I'm just going to test the reflexes in your leg here.
Yes.
Okay. So I'm just going to do one up here for me. Might jump your leg a little bit.
Yes.
We're looking for any clubbing or cyanosis, any Dupuytren's contractures, palmar erythema, or any other signs of liver disease. Can I ask you to extend your hands out for me and bring your hands back? Looking for a flap. Thank you. That's great. Okay. Moving up now to the head and the neck. I'm going to look at the eyes. First of all, could you look up for me? Looking in the gutters for any pallor, looking for icterus, the jaundice of the sclera, and any xanthelasma. Could you open your mouth for me? Looking again for central cyanosis, any ulcers, abnormal pigmentations, or other signs in the mouth. Okay. Moving down now in our inspection, looking again at the chest, noting the body hair, any gynecomastia, or more spider nevi on the trunk. Moving down now, we come to our inspection of the abdomen itself. The things that we're looking for here are any abnormal distension, any masses, any distended veins, or any abnormal pulsations. Now we'll move on to the palpation of the abdomen. And for this, it's important to get down on your knees so that you're at the right level for palpation. So now we'll move on to our palpation of the abdomen. Starting with palpation with light touch, asking the patient if they've got any areas of tenderness. Have you got any tenderness in your tummy?
No.
Can you let me know if anywhere's tender?
Okay.
Lightly palpating in each of the 9 areas of the abdomen. Now to move on to our deep palpation, we'll firstly be palpating for the liver, starting in the right iliac fossa. Could you take a deep breath in and out for me, please? Okay, starting again in the right iliac fossa, moving diagonally over to the left hypochondrium to feel for any enlarged spleen. Again, you take deep breaths in and out for me. Good. Next we move on to palpating for the kidneys. If I could just move your arm. You need to get one arm underneath the patient, one hand on top, and you gently try to blot the kidneys upwards and feel between your hands for any enlargement. And again, over to the other side. Okay. Finally, palpate for any aortic aneurysm. Next, moving on to percussion. Firstly, trying to percuss out the liver. starting from well below and noting where the bottom edge of the liver is, and percussing down to the top edge of the liver, making a note of the size. We percuss again over the left hypochondrium. Finally, percuss for shifting dullness, percussing in the flank, the note of which should be resonant. If there's any dullness in the flank, ask the patient to roll over on the left hand side. And percuss again to ensure the dullness has shifted. Right, finally we auscultate the abdomen. That's great. Now we can ask our patient to sit forward. Would you mind to sit up for me? With the patient sitting forward, inspect the back for any renal scars and auscultate for any renal bruits. While the patient is sitting forward, we can complete our examination by feeling for any cervical lymphadenopathy.
How she moves. So if we look at her bending forward, what she's done in the past, the last 18 months, is she's been very guarded. So when she moves forward, she basically moves forward in extension. Now that's fine if you're lifting something really heavy. You need to keep yourself in a neutral position. But if you're just bending forward day to day, you can't keep yourself locked up in there. So her spine, because it's her spinal multifidus muscles and all her stabilizers are sort of tonic, they're not really working very well, they're very static. She's got what we call static stability, but she doesn't have functional stability. So when she moves, she has to hinge the hips. And what it'll do is it just means she can't bend very well. She'll just fatigue a lot because they're not working as a stabilization component. They're just getting held static. So if you have a look at this, what Dinah does in the past is when she bends forward, if you just go forward for me, Dinah, what she tends to do is she's in full extension there. That's like a deadlift position, right? Come up again. It's almost like a perfect deadlift position when you're lifting something 100 kilos and you're lifting off the floor. That's great. But not when you're just bending forward and picking up something off the floor, or you're bending forward and picking something off the table. So what we're going to try and get her doing is actually getting these muscles from a tonic state to an active state so they can actually control her and let her go into flexion. So if you go forward for me, see if you can release that a little bit more. We've got to try and get her rounding out here a little bit more when she's picking up something light in everyday movement, but of course come up. Get her strong enough in there so when she's down the track and she's exercising that she can maintain that neutral spine when she does lift forward to strengthen it up and it doesn't fail on her. Okay, so that's the first thing. We've got to try and get strengthening work up in here to allow her to actually hold stability and let go and move, so it's more functional for her. Let's get her back up on the bed. I want to show you what happens with Diana. Have a lie up on your back for me, Diana. Do you want to come around? Yep, up. Just put this down. So, if you think about Dinah, she's got actually quite good transverse abdominis control. So she's got quite good anterior control. And the reason for that is she's had spinal surgery in the back. So in the back, the muscles are wasted, they're not as good. Okay, so her main problem is she can't stabilize at the back very well. She's learned how to stabilize in the front. She's actually surprisingly good with that. The other type of people who have problems in the front, more like say post-pregnancy, okay, post-childbirth, that sort of thing, where they've lost their control in the front, and what tends to happen is they are not very good at controlling their forward and back movement when they're in this position. Dinah's actually quite good because her control in the front is good. This hasn't been compromised. It's her control in the back, and so her rotation is really poor. And you'll see that when we do a knee fall out, she can't control that rotation of her pelvis. It tends to shift and roll like a boat, where she's good at the forward and back, the anterior posterior movement. So for someone who's been carrying a baby or has had pregnancy or abdominal surgery, when they lose that control in the front, they tend to compensate and work on their muscle in the back increase. So the actually muscles in the back are actually really strong. Their multifidus tends to be working quite well. Unfortunately, it's working too much, so it fatigues. So they still get back pain, like Diana gets back pain, but their back pain is related to over fatigue from the muscles working too hard. Diana's back pain is because the muscles aren't working. All right, so we've got to try and get those going so she gets her control from front to back a little bit better. So let's look at this. If we worked on her core, we worked on, she's really good at bringing on her pelvic floor, bringing on her stabilizers, so she knows how to work on that. What I want to show you is rotation control, a lack of rotation control when she doesn't switch anything on, when she's just normal state. And we want to be, like, ideally she wants to be having that control without thinking about it. At the moment she has to think about it. So let's show you this. What I want you to do, Diana, is you're going to move your left leg out to the side like that. This is called a knee fall out. On Pilates they call it a hip twist. So she's going to have one leg stable, her left leg goes out to the left. I want you to watch this pelvis where her hands are. Just keep an eye on this. What you'll see is this pelvis will rock like a boat that way instead of staying stable. So let's try that. So Diana, you just try and let that left leg fall out to the side. See how she moves over to the left. That's not supposed to happen on normal stability. Come back in. She's supposed to be stable. So if we get her bringing on that pelvic floor, so breathing out, bring that pelvic floor on up to that 30%. So she's stable through here. She gets that abdominal tone, that transverse abdominal tone. She's got to keep that on, and I suggest breathing in as that leg goes out. So you watch the pelvis now, breathing in, and then breathing out as she draws back. Can you see how she keeps that way more stable now? That's awesome, all right? But that she has to think about that consciously a moment. In time, when she gets stronger, she gets more endurance than that, she will then, it'll just happen naturally. She won't have to think about it, which is what we want. We talked about the rotation control of her multifidus at the back, how that's not really working. Let's have a look at that in 4 points. So if you go up into all fours for me. Yeah. So on all fours now, 4 point, horse stance, whatever you like to call it. Okay, so she needs to be, this one here, again, we need to be a neutral spine at this point here. She tends to sag a little bit, so we're going to try and get her a little bit more aware of, okay, you need to be up into neutral, so that tiny little posterior tilt, so she stays in that position. Again, don't forget about what's happening up the scapula. Get that a little bit up in neutral, get that head nice and long. So from there, she's got to try and control and make sure that she doesn't move her spine when she raises one arm. We're going really low level here. We're trying to get one arm forward at a time. So she's going to, if she's balancing on 4 points, we're going to go, okay, 2 legs, 1 arm, can you raise 1 arm? Now, when she doesn't use her multifidus, when she's just naturally, at the moment, she's just naturally not thinking about it, what tends to happen again, she will shear and rotate. And that's no good when you're walking. Imagine when you're walking, that pelvis is shearing and rotating, and those poor lumbar discs over time are going to get a lot of wear and a lot of use. Because remember, she's fused from up here. She's fused from L2 to T12. Okay, so she can't move there. She has to compensate and move here. So if we're going to get her looser here, and I'll show that extension in a minute, if we're going to get loose here, we have to get her stable and strong at the same time. We can't loosen someone up and then not have the strengthening, the stability, because otherwise she's going to fall apart and feel very vulnerable, and there's going to be more wear and tear, and then more lockdown, more guarding, more problems. Okay, so let's see what happens when she raises her left arm forward. So have a look at the back. So come over here, take a look at this. I want you to see this rotation. So without thinking about Diana, I just want you to raise your left arm forward for me. Okay, can you see how she just instantly moved across the right? She didn't trust, her body, her subconscious didn't trust the fact that she could stabilize through 3 points, because the connection in the middle is not really there. So she went, okay, left arm, or I better compensate, I'm going to go straight across to the right. So now if we try and get her engaging, her thinking about it, bring it up a little bit more over there, that's it. Again, she drops an extension, we've got to correct her a little bit there, back to neutral, breathing out, pelvic floor on. Now don't forget about multifidus, she needs to fire this up. Okay, so she needs to pump up her multifidus by tensing that up, she needs to hold that on, and then she's got to try and raise that left arm. See how she's really fighting that? She's trying to twist a little bit now, so she's got a little more control, so she can trust her legs. But again, when she brings that on, because it's weak, she still gets the shear in here. So before, she wanted to just, oh, I'm not even going to use that, I'm just going to shift away. Now she's telling her, no, you've got to use this. It's not strong enough, so she tends to rotate in that point, and that's what we've got to try and get better. Multifidus first, and then those rotatory muscles. So that's something we really got to work on. The other thing is, remember, you drop onto your front for me, Diana. Yep, face down. Her extension, she can't extend. She's fused. She can't extend between T12 and L1. Okay, so and we don't try and with physio, we don't try and mobilise that. It's a fixed surgery. We don't have to worry about that. Very interesting though. She's had a spinal rod on this side. So the cage sits in the middle. She's got a spinal rod fused on this side. She's sore on this side. But she's actually getting less sore the more strengthening work she does. I want you to see what happens when she extends. Now we've got to don't be afraid of extension. We need extension to function. So this part here needs to extend. We can't have this solid and weak. A tonic sort of system. We need it moving. Yes, it's going to bend more over her lifetime in this year, but if we've got the control, that's great. So if you go into that McKenzie extension, now this, if you look on our other video, McKenzie extension, this is what she's trying to do. What I want you to look at is where she doesn't move, all right? So if you come up for me, Diana. Up
Just
you go.
normally?
Yep, just normally. So pushing down, breathing out. What I want you to look at is check out where she's bending. Okay, she's bending at the only point she can. She can't bend here. She's bending normally here. See that little curve there? Look where she's not bending. Okay, so she's not extending as well as this side. So her left-hand side is not extending. It's not extending because she's sore, she's tight, she's vulnerable, she doesn't like that area, she's been 18 months guarding it, it's tonically active, on here, it doesn't want to let go, and she's stiff in there. Drop down again for me. So when we mobilise this here, obviously we don't mobilise up here, but when we mobilise in here, what tends to happen is it's quite stiff in there, okay? And when we were mobilising before, it was actually getting less stiff and she felt less sore. Whereas on this one, on this side, she's got heaps more movement on that one. It still hurts because she's sore, but if you look on this one, it just doesn't want to go. So our mission is to loosen that up, and her mission is to try and get extend at that point and get her loose on that left-hand side so her extension movement's better. Now when her extension is better, her range is better, she's got more likely chance to switch on those muscles as well to then stabilise it. Okay, so that's with Dinah. Check out part 3. We're going to go through some more glute work and some rotation work, because in the end her biggest problem is multifidus in a nutshell, and then rotation. So we're going to have to go from getting her being able to extend actively, being able to flex actively, having control through that movement, and then getting her to the point where she can deadlift or she can pick up something that's not too heavy to build up that strength in a multifidus, and then get her into rotation work. So we'll start doing some rotation work, which you'll see later on.